All right, good morning, everyone. Thank you so much for joining us. I'm Jackie Burgess Bishop, and I have the great privilege of serving as the CEO for the National Kidney Foundation of Illinois. Dr. Hayes expresses her regrets that she isn't able to be here today. So I am, again, very pleased to welcome you here to launch the update of this impactful work we have completed at the summit to date. Before we begin, we want to acknowledge in terms of I don't see any, but just want to acknowledge if there are any elected officials or VIPs, but to me, all of you are VIPs, so you can stand. But if there are any elected officials, we just would like to acknowledge. And Emily, our other summit co-chair, she also plans to attend, and she welcomes you as well. So the Ending Disparities in Kidney Disease Leadership Summit we hosted in June 2023 is part of a national strategy to advance health equity in the identification, diagnosis, and intervention of kidney disease in populations that have a disproportionate burden of disease, specifically communities of color. Our ultimate goal is to shift the paradigm of kidney disease from a focus on end stage to a focus on early diagnosis and reducing the CKD impact. In order to do so, we used a collective impact approach to bring together key stakeholders from around the state to identify the strategies and recommendations we're currently advancing. Last year, we convened 4 work groups to identify successful strategies and develop recommendations to improve primary care management of CKD. These recommendations were the result of 16 hours of facilitated discussions with 38 healthcare and public health leaders across 29 institutions in the state. The working group recommendations were then ultimately distilled and used to compose the statewide strategy. We developed 11 recommendations to improve public awareness and understanding of chronic kidney disease, provide clinician and health system opportunities, build the case and change the conversation, and leverage policy, payment, and quality measures. During today's program, you will be hearing from our speakers on 2 of our recommendations, including the importance of implementing a data strategy and development of a kidney-specific curriculum to educate and empower our community health workers. What we wanted to do at this time is just to talk about that navigating of the roadmap in Illinois, and those of us here in Illinois know that we are early adopters when it comes to, to public health, healthcare, and wellness. So in Illinois, as early adopters, we know we've had the Kidney Mobile, since 2005, screening over 50,000 persons, have with collaboration, and that's what this slide is about. It talks about what can be done with collaboration and partnership, because no one entity can have these accomplishments alone. So with the Living Donor Protection Act in 2019, I see people in the room that were with us as we went around to get that act passed. We are part of, a number of members here are part of the Illinois Kidney Disease Prevention and Education Task Force that initially passed in 2019. I think we all know what happened in 2020, and so it was reauthorized in 2022. In looking at SDOH partnerships, or social determinant of health partnerships, what we did, what I would say NKFI and other partners, what we were able to do, we could not take the Kidney Mobile out as an example, but we used the Kidney Mobile and partnered with food distributions, and working with organizations that were helping persons with housing, nutrition, and we provided education about kidney disease. We've launched a podcast that was supported by our Donate Life Illinois partners. I see a number of our Donate Life Illinois partners here. And since 2020, we've had over 10,000 downloads, and launching the Kidney Health for Life public awareness campaign in 2021. We've had, and some of the statistics are there, direct engagement of community health workers in linking communities with social determinant of health services, educating on kidney disease, and supporting kidney mobile screenings in focused communities and counties throughout the state. And of course, supporting our NKF national campaign of Are You the 33% through our partnership with the Links. So here we are, and as we look at that intersectionality that I just discussed with kidney health initiatives, where we are in terms of leveraging these valuable assets through a population health collective impact model. And that's what we've been working on and discussing some of the progress to date, with the goal of population and system level change. So Illinois as a state, we continue to level up, looking at technology, innovation, data metrics, and quality. So since June of 2023, we talked about, under the category of improving public awareness and understanding of CKD, as a result of our intersectionality with the Illinois Kidney Disease Prevention and Education Task Force, we held 2 open forums in Chicago and Rockford in November of 2023. We were able to collaborate with the American Diabetes Association meeting with other partners in November in 2023. That came out of really one of our work groups in terms of looking at kidney disease, how the amplification occurs, and also looking at partners from a chronic disease perspective. In terms of building the case and changing the conversation, that particular group, we're going to talk a little bit, Dr. Lash is going to talk about launching the data strategy, and then with the clinician and healthcare system opportunities. And so these were all part of our recommendations, broad-based recommendations. Educating and engaging community health workers with the Illinois Kidney Care Alliance and NKF. You're going to hear more about that from 2 of our speakers. And exploring opportunities to pilot engagement with the cardiovascular, it's a federal cardiovascular 2304 program that passes through to the state. So with that, it is my privilege, I have to get the total introduction. He hates it when I do this. He said, oh no, I do this. The total introduction for Dr. Lash. Welcome, Dr. Lash, the Robert Wood Keaton Professor of Medicine and Chief of the Division of Nephrology at the University of Illinois at Chicago, UIC College of Medicine. So thank you, Dr. Lash.
Thank you, Jackie. Really happy to be here today. So we in UI Health, we were approached, and of course we're very interested in this partnership and to take part in this data project. And as you know, UI Health is a public funded institution, state funded, and so it really falls within our mission to try to better understand CKD, prevention of CKD. We serve a large population of patients of diverse backgrounds in both the west side, south side, north side of Chicago. And our practice also includes the academic affiliate of Miles Square Health Center, which gives us another opportunity, because since Miles Square is a very large FQHC that serves, it's one of the few academically affiliated FQHCs in the U.S., and as part of UI Health, so it really will also afford us the opportunity to look at different areas within our healthcare system. So as part of this process, as always, when you have to analyze data, we had to have a contract, and so that went through pretty quickly, given how contracts can be, and where we will be able to provide de-identified data on our at a high level on our patient population. And we've also initiated some of the initial analyses, which are pretty straightforward, but very important. So the size of our population, the number of patients who have a coded diagnosis of CKD, and we expect that to be underreported, and that's certainly nationally is underreported, so that will be an area that we will need to work on. The size of our population that's at risk for chronic kidney disease, so the number of patients in the healthcare system that have hypertension or diabetes, the number of patients who've had appropriate testing, so either an estimated GFR, an albumin determination, and then the number of patients who, by appropriate testing in the outpatient care center setting, have CKD. So we'll be able to sort of take a look at that and sort of look at opportunities in terms of recognition of CKD and screening for CKD. And we expect that we'll identify many opportunities for which we'll be able to do targeted interventions. So we're excited to participate in this, and eventually down the line, I think we're also going to be looking at treatment, use of renal protective agents. But I think in this first wave, we're just getting a idea of size of the population, and where the needs are. So that's really all I had to say, but we're very excited to embark on this collaboration. We've had previous great collaborations with NKFI and the Kidney Mobile and other programs, so we're excited to continue it. And if there are questions from the Zoom audience, please put them in the chat or in the QA. And I'm happy to take any questions now. All right, well, thank you very much.
Good morning. It's good to be here with you today. I'm Elizabeth Lively. I'm the Eastern Region Advocacy Director of Dialysis Patient Citizens, a nonprofit organization that is focused on advocacy and education for kidney disease patients. And I'm going to talk to you today about, where's the clicker here? Here we go. About a community health worker initiative that DPC created and took to the Illinois Kidney Care Alliance. IKCA is a coalition of healthcare providers and businesses, community organizations that are dedicated to keeping the needs of kidney patients in the forefront of the members of the Illinois General Assembly. We took the concept of the community health worker as a new ally in educating communities about kidney disease to the IKCA, and a task force was formed 2 years ago in July of 2022. This curriculum that's being developed is really filling the gap. When you look around at other community health worker training that is available, there's a lot of specific chronic disease education, but nothing specifically for kidney failure, and that is the gap that IKCA is looking to fill. 12 members of the coalition came together. You can see their names here. It's a pretty impressive group, and we have come a long way in the last 2 years pulling this program together. The driver for this really was that government payers are now looking at community health workers as a new entity, and they're coming up with reimbursement mechanisms through Medicare and Medicaid, which will really help community health workers have a sustainable paycheck and not have to depend upon grant funding. So you won't see that stop and start of their work, but you'll see a consistent work in the kidney space with these individuals. So the goals of the task force, really the three major goals, were to prevent or slow the progression of kidney failure. 85% of people who are on kidney dialysis did not know they had kidney disease, and they crashed into it in the emergency department. The worst place to know that you have a major chronic condition and that you are going to be on dialysis for the rest of your life. And we wanted to lessen racial disparities in the kidney space with kidney transplantation and access to home dialysis. When you're in the emergency room hearing that you have kidney failure, that's not when you're interested in learning about all of the different modalities of kidney, how you're going to treat your kidney disease. And by getting these community health workers upstream out into the communities, educating people about chronic kidney disease and helping them to slow that progression, and if they are progressing, to know what their treatment options are going to be in the future. How do I plan for a kidney transplant? What type of dialysis do I want? Am I interested in home dialysis? If I am, do I want to do home hemo? Do I want to do peritoneal? Do I want to do in-center dialysis? The community health worker can play a pivotal role in educating these individuals. So the task force is focused on 2 career pathways. One focused on chronic kidney disease that is a patient navigator that can work in a number of different healthcare settings, can identify individuals who are on that trajectory towards their chronic kidney disease progressing into end-stage renal disease. And to work with them and with their families and with their communities to learn how they can be empowered, how they can take control of how their disease is moving forward. Can they stop it? Can they control it? Can they slow the progression? And helping patients understand that that is within their control to a large degree will be a role of the community health worker. The second career pathway is a specialty role for individuals who are in stage 5 chronic kidney disease and they are starting dialysis, helping them with home dialysis, perhaps going to their home, helping to do a survey of how they're going to set up there, helping educate their families about what to expect with home dialysis, partnering with the patient's care team to help that be seamless moving into home dialysis. Questions about hemodialysis. What does it mean to cannulate yourself? Is that something that I could end up learning how to do myself? So the community health worker can provide that information, not getting into the clinical areas, but helping to answer questions, to allay fears, and again, empowering patients. So now the work of the task force is in the actual training curriculum development. We are so excited about this. And we have the logos that are up here. These are the main individuals from within and outside of the task force that are working on this curriculum training. The Baxter Black Care Program, Dialysis Patient Citizens, the National Kidney Foundation of Illinois, the National Kidney Foundation, the University of Illinois, the Diversity and Aging Laboratory, and the Illinois Public Health Association. And with that, I will hand it over to Dr. Smith from IPHA to talk more about the curriculum.
Thank you very much. So I'm really excited to share about our curriculum. This started out as setting the objectives for a curriculum from the task force that was originally developed. And then as we moved to working with the curriculum collaboration partners, we tried to identify what was already in existence so that we did not duplicate the efforts of reproducing something that was already there. So we took what was there and we plotted it out against those different objectives that were laid out. So as you can see here, what we have said initially is that students must complete the core CHW curriculum training. That curriculum training consists of at least 13 core competencies that are nationally recognized for community health workers. After they have, and that training varies, there's different ways that training can be done in the nation and in Illinois, but they have to meet those core curriculum components of training. Then we have laid out 8 modules that are very specific to this space. And again, like I said, these were based off of those objectives and those learning directions that came out of that task force work, that then as it moved to curriculum, we put it into a module layout. So beginning with the kidneys and you understanding that general concepts, and then moving towards coping with the diagnosis, the trauma, and the grief. For all of this, we have developed modules, worked with existing modules, added to those modules so that they're available for individuals who would like to complete this. The curriculum timeline, all of our modules will be completed by mid-April. We're really, really close, which is really exciting for those of us who's been working on this. We're excited to have that done. The pilot training will open May 1st through May 15th. We want to pilot this with a group of already CHWs working in this space, so they can give us feedback so that it becomes a truly coordinated effort of development, right? We don't want to leave the community health workers out in their feedback to us. How does this curriculum work? What is it? Do we have everything included? Are we providing it in an implicit bias, aware of implicit biases? Are we offering it in an equity-based direction and trauma-informed, right? We want our CHWs to give us that feedback. So that's our goal of our pilot. We'll then use the month of June to revise before we go live with an open access training from July 1st through August the 5th for these online modules. This will be open to any CHW in the state of Illinois who wants to sign up to take that. But what we feel is real, and those will all be done asynchronously. What is so vital that we've found is we have built out CHW programs, and we've used other training programs that we've developed, the lessons learned from those, to put this together. And one of the critical spaces of that is asynchronous learning is great, but we have to have some time together to practice this, to what are the barriers, how are we going to respond, to ask those questions, right, to do those simulations and stuff. So that's what we will be holding on August the 21st. It'll be held at the 2024 IPHA CHW annual summit that we have in Springfield. And for that first day, we're having a bunch of different workshops and trainings, and this will be one of those. So we're excited to be able to bring everybody into the same space to practice case scenarios, to practice responses, because this is one thing we're really well aware of with our CHWs is that they often, receive a lot of possible re-traumatization and vicarious trauma related to the work that they're doing. So we feel having this in-space training allows us to address those wellness concerns too for our CHWs. So what's happening just quickly with community health workers in Illinois? Well, at Illinois Public Health Association, we developed the CHW Capacity Building Center through some funding, through congressional district funding, because we saw the need to help integrate CHWs into practices. So it's great for us to train, but if we don't help sites that are practicing healthcare centers integrate CHWs into their work, it doesn't create that closed loop process that's so important for CHW. So this is the focus of that CHW Capacity Building Center. So the curriculum is great, but now the next big steps come for us, right? Taking it out and getting it integrated, and that's where we'll focus at. In the state of Illinois, there's a lot of great things that are happening with community health workers. The Community Health Worker Review Board is meeting regularly, putting together the recommendations for curriculum training in the state of Illinois that will lead to a certification that's recognized by the Department of Regulations for community health workers. That should help to lead the path to being able to be a billable service through Medicaid and Medicare. We're real excited that Medicare came out with the codes for CHWs to be able to bill. We are looking to see when will that be able to go live in the state of Illinois. We have a lot of places that are ready to do that, and I think this CHW program with navigation for chronic kidney disease is the perfect place to pilot that, see how it works, and to get a jump start on that. So we're hoping that, and we have a lot of sites that are interested in that, so we'll continue to work towards that. If you have any questions, you can reach either Elizabeth or I at this number. And I'm excited now to pass this off to Megan, who is the Population Health Partnership Director at the National Kidney Foundation. So Megan Schultz, I think you're going to pull her up for me.
All righty. I hope you all are seeing full screen on your end there. Awesome. Well, thank you so much. I really appreciate that, Dr. Smith. My name is Megan Schultz, as mentioned, and I am a Population Health Partnership Director at the National Kidney Foundation. And I have had the pleasure of working to develop and deliver programs that aim to improve CKD care and patient lives through early identification and appropriate diagnosis, specifically through the Ending Disparities in CKD Leadership Summits that we are advancing across the nation. And across this deployment, and improve public awareness of chronic kidney disease has been a common theme articulated in many of our discussions with key stakeholders, which has resulted in recommendations as noted here on this slide that include leveraging community health workers to increase understanding of chronic kidney disease and support of chronic kidney disease screening and appropriate diagnosis. And in the states denoted here on this slide, you can see that CHWs were mentioned in each roadmap as they are an extension of the care team and can play a critical role in expanding chronic kidney disease education and support of both at-risk and diagnosed CKD patients, and really serve as trusted CKD ambassadors to support care coordination and chronic disease management. And following this recommendation that first arose in Missouri as the pilot project state for this National Health Equity Initiative, the National Kidney Foundation conducted insightful CHW interviews and a CHW conference session at the NKF spring clinical meetings last year in 2023. And from the robust discussions that were held, we collaborated with a community health worker committee of members across the state of Missouri, as well as in partnership with the National Association of Community Health Workers, to create an educational video series that we then were able to develop for community health workers and host on our NKF webpage that offers specialized training with completion certificates for participants and additional tools associated with the modules for patient engagement in chronic kidney disease awareness and management. And our aim is ultimately with this toolkit to find opportunities to expand the reach by building partnerships with local community health worker associations and accrediting bodies to really disseminate this free educational resource far and wide. So what have we learned thus far through this new National Kidney Foundation strategy? Well, understanding the various accreditation requirements is important as it varies from state to state across the nation. We've also learned the importance of really integrating that CHW personal experience or insight, as that is really important to be heard across these modules, as well as finding opportunities to really meet community health workers where they are at, and disseminating this resource is important in terms of finding common places of gathering and integrating a module demo or promoting the toolkit there. And we are not just stopping at education with this toolkit development. We're also exploring opportunities for community health workers to lead CKD risk screening interventions through pilot programs. So demonstrating the tangible benefits of community health workers and enhancing chronic kidney disease screening and management across vulnerable populations. And you can see here on this slide the goals that are articulated here in terms of being able to evaluate community health worker effectiveness at improving screening and testing rates, supporting care coordination and follow-up CKD care, as well as continuing to increase chronic kidney disease knowledge and self-efficacy. And last week, I actually had the opportunity to attend a community health worker conference in Missouri, and we had a roundtable discussion with 14 community health workers to unpack opportunities to really strengthen the effectiveness of this pilot intervention design to engage community health workers in connecting at-risk patients to appropriate testing and care. And you can see a particular discussion board here noted on the screen in terms of really unpacking those barriers to testing and understanding from the essential community health worker perspective how we can address those barriers. So we look forward to moving into this next phase. And then, as previously mentioned, later identifying opportunities to advocate for appropriate reimbursement of community health workers in a chronic care model. So how can community health workers across the state of Illinois and nationally support this improved public awareness strategy in the NKFI roadmap? Well, again, our modules are available on kidney.org webpage and free to those who would like to complete this education. So we encourage completion of those resources, as well as playing one of those recordings at a live CHW meeting and promoting the additional resources that are a part of the toolkit. We are also looking forward to continuing to add additional tools to this hub. So if there is interest from community health workers across your network in being a presenter for one of the modules, or interest in developing content for a particular topic, we would love to collaborate on that piece and work to develop the tools associated with that topic. We know, again, that this is March, National Kidney Month, but we want to promote kidney awareness all throughout the year. So encouraging community health workers to disseminate NKF or NKFI patient educational materials, and the risk quiz, as Jackie previously mentioned, is something that is very important. And then as we move into this next phase and looking at the pilot intervention of engaging community health workers and connecting those at risk to testing and appropriate care, we are interested in connecting with community-based organizations and institutions to talk about what that model could and would look like in their institution, and how we can dive deeper into their data and look at opportunities to set metrics for driving improvement and kidney health outcomes. So that is what I have to share today in regards to our national strategy, and looking forward to collaborating with you all and really changing the trajectory of chronic kidney disease together. Thank you.
So we want to thank Dr. Lash, Liz, Elizabeth Lively, and Dr. Tracy Smith and Megan Schultz for their presentations and advancing the knowledge. At this point, it's my privilege to provide a brief introduction of our keynote speaker, Donald Du. So Donald Du has served as the president and CEO of Habilitative Systems, Inc. for 34 years. HSI, as it's known, is an essential Chicago-based behavioral health and human service organization providing programs and services for thousands of children and families with special needs. Mr. Du is currently board chair of the International Commission on Accreditation of Rehabilitation Facilities, the Board of Trustees, also known as CARF. He is a commissioner of the Illinois Guardianship and Advocacy Commission, a board member of Wellness West, and Collaborative Bridges Healthcare Transformation Collaboratives. He received his Master of Social Work degree from Jane Addams College of Social Work at the University of Illinois, and BA in Social Work from Lewis University. So welcome, Donald. Thank you.
Good morning, everyone. And thank you so much, Jackie, for that introduction. You know, it seems like only yesterday that I was a little boy running around the streets of the West Side, just a few blocks from here. Grew up right here at 1848 West Adams. And, you know, I always say, and I'm saying this increasingly, Jackie, that I'm a product, really, of social determinants of health. And one might ask the question, well, what do you mean by that? Well, I was born right here at Cook County Hospital. I received speech therapy at Rush Presbyterian St. Luke's Medical Center back in the day. And my mother became a community health aide at Miles Square Health Center back in the day, over 50 years ago. And it was very, very interesting that in that role as community health aide and reaching out into the West Side communities and areas that, of course, were seeking equity in healthcare, they went into projects like Henry Horner, and they were identifying folks with chronic health disease conditions, right? And they were able to get them into Miles Square and get them screened and get them the treatment that they needed. And I, as a young guy, teenager growing up on the West Side, had my very first professional work experience at Miles Square Health Center. So I'm telling a story here, folks, okay? There's something to this model of community health workers. There's something to being able to reach into the community and engage folk and ensure that folks are educated and create significant advocacy efforts for folks to really learn more about themselves. And increasingly, and I promise I won't preach today, but you know, what we're really talking about here is a healthcare movement, right? We're talking about a healthcare movement. And it's real simple when you think about it. You can't heal and hurt the community at the same time. You got to make a choice. So I'm trying to get more and more folks to make that choice about being a part of the healing process within the community. That's my commercial for healthcare today. All right. So I'm here to really talk about social determinants of health, social drivers of health, and our role at Wellness West in really moving this effort forward around healthcare transformation within the state of Illinois. What really got this process started in terms of funding mechanisms was the Illinois Black Caucus coming together and developing, after George Floyd's unfortunate death, the 4 pillars to deal with health equity, racial discrimination, and a number of different issues and systems throughout the state. And they really were able to determine that the best way to approach this was to look at the 4 systems that were primarily affecting those folks that were the most affected by systematic discrimination. Looking, of course, within the criminal justice system, we could talk about how we went from the war on poverty to the war on crime, which of course led into the war on drugs, which led to mass incarceration, but that's another whole lecture. I want to go into that right now. Then we can look at, of course, the pillar around education and workforce and how incredibly important it is to make sure, as we've heard today, educating the workforce, right? Community health workers and their importance. And we know about Malcolm X's community health worker program and Sinai Institute's community health worker program, and I'll speak a little bit more about that a little bit later as well. And by the way, I'm talking fast because my mom is from Louisiana, and that's just how they talk, okay? If I need to slow it down, a little bit, you all just let me know, okay? All right. But it's in the DNA, all right? So we also, of course, looked at the pillar around economics, access, equity, and opportunity, and then lastly, of course, healthcare and human services. And then, of course, just a quick timeline, looking at what was going on in 2020, July of 2020, Illinois General Assembly passed enabling legislation to create a healthcare transformation program in November. DHFS announced the equity-centric healthcare transformation plan 2021, fast forwarding. Governor Pritzker signed into law the community-driven, equity-focused healthcare and hospital transformation bill. In June, Illinois announced awards totaling over, $95 million. I don't have my glasses. I've got it. Yeah, over $95 million to equity healthcare. In October, Westside Health Equity Collaborative formed as a non-for-profit. And I'll tell you a little bit more about that in a minute as well. In 2022, looking in January, relationships established with 30 providers across the west side of Chicago. By February, first employee was hired, more than 100 employees today. Think about the workforce development piece, right? April, our first health risk assessment was completed. October, the name was changed to Wellness West. Now, I'm talking fast and we're going through years of planning, but just think about the fact as a central theme, there's really power in collaboration. One of the central themes have been collaboration. And I'm really going to do my very best this morning to give you a powerful example of just how powerful collaboration can be when you're talking about equity in healthcare. So, looking at the 15 innovative partnerships funded across the state, healthcare transformation collaboratives through the Illinois Department of Healthcare and Family Services. We're talking about what? Sustainable strategies. And I've been around, ladies and gentlemen, long enough, over 40 years, in human services, in social work, in healthcare. I've seen a lot of different initiatives come and go, more than I want to really talk about this morning. But it's really about how do you sustain an impactful strategy. It's one thing to come up with a good idea, but how does one really institutionalize that idea and make it stick and make it continue to have impact within the community? So the Medicaid Working Group is a collection of lawmakers that's been tasked with reviewing Medicaid legislation, rules, and policies. The group also proposes legislation based on their review to expand access to healthcare services, preserve existing healthcare coverage, and increase equity within the Illinois healthcare system. Wellness West is currently meeting with members of the Medicaid Work Group to support sustainability. Once again, it's one thing to come up with a good idea, it's another thing to sustain it. So we've got to think about what are all the great things that we talk about here today. We got to think about sustainability of the effort, sustainability of the impact. So, in summary, when we talk about from hypertension to diabetes to housing to food access, Wellness West is measurably improving the health and wellness of thousands of patients on Chicago's West Side. And here are some of the results that we've achieved thus far. The west side of Chicago suffers disproportionately from higher rates of chronic disease, acute ailments, and mental illness. Wellness West was created to address this health inequality. Now, when you look at the zip codes represented here, we're talking about basically fundamentally 10 zip codes on Chicago's west side that are significantly adversely impacted by issues around inequity. You're talking about a health care, or rather I should say a mortality differential of folks living downtown from folks living on the west side of Chicago of roughly about 15 plus years. So you mean to tell me that your zip code really determines how long you can live within the city of Chicago? Think about that for a moment. We used to walk, literally walk, from the west side, near west side of Chicago, downtown to the lakefront. We used to walk that. A few blocks from 404 to 60612, there's a 15-year differential. Okay, I won't go all the way into that. But let's just say that, our purpose is to create an unprecedented collaboration, unprecedented, for the uninterrupted continuity of care among hospitals, outpatient care, social service network, and community residents. Now, when we talk about unprecedented, we're talking about unprecedented because when I say that I've been involved in a number of consortiums and collaborations over the years, for example, many of you all remember with the American with Disabilities Act, of 1990, we were talking about what? Creating equitable care for persons with developmental disabilities and people with physical disabilities. And we talked about dealing with all these institutional barriers to people with disabilities. But it was the 1990 American with Disabilities Act that made it possible for what? Millions of people in institutions to become integrated in the community. One act, American with Disabilities Act, made that happen. We were part of the Equal Access Panel in the city of Chicago that basically fundamentally said we wanted Chicago to create the most accessible central business district in the country. Now, some of you all in this room, not everybody, but some of you all are old enough to remember that we didn't used to have Braille in elevators and curb cuts and elevators talking to you, letting you know what floor you're on. Some of you all, anybody remember that? Okay, all right, that's all right. I won't go any further with that. So, who are the partners involved in Wellness West? We're looking at our community health centers, access. I won't go through all the list of folks. You can see it here. We've got hospital systems, community mental health centers, community-based organizations, and other partners. I'm telling you, I have never been involved with a collaborative effort that has really brought this a diverse group of folk and entities and institutions together to have impact in a targeted area. It's never happened before. And this is why we have to be able to publish it, we have to talk about it, we have to promote it, we have to educate more and more folks. And I say there's one thing to be an expert, there's another thing to be an advocate. There's space in the room for everybody, right, who are experts and advocates. But we're trying to get the grassroots folk involved. That's really the key to it all. When you all talk about engaging and educating and coming up with a curriculum of training for community health workers, that's really the key. You build a fire from the bottom up. That's how it gets started. When you get the energy going on at the grassroots level, that's really what takes it to the next level, okay? Now, let's look at the investment in this care model. We're not just talking, we can talk about quantitative outcomes, we can talk about qualitative outcomes, because both are very, very significant, okay? Now, let's look at expanding access to specialty care, funded at over $950,000. Expanding access to behavioral health, over $1,500,000. Supporting MBEs, WEs, over $3 million, almost nearly $4 million of investment, okay? We're not just talking about a good idea, we're talking about investing in a good idea. There's a difference, would you all agree? It's one thing just talk about it, there's another thing to invest in it. Well, look at the investment. Over nearly $25 million has been invested in this concept. Nearly $25 million. This never happened in my lifetime before. And I don't want it to be the last time either. I want to see more of this, okay? So let's look at these social determinants of health that influence 50% of community health outcomes. 30% health behaviors, another 20% around clinical care. And we came up with a standardized tool that we use for universal health screening. Can you think about the fact and how long it took us all to agree on a universal health risk screening tool? But we did it. Our clinical care committee sat down and did it. And we were able to look at all these different social determinants of health that we could agree on were significant in being able to determine the outcomes that we wanted for these 10 zip codes. Now, back in 2020, let me just digress for a moment, habilitative systems was what they called an intermediary for the census in the city of Chicago. We were in 8 community areas on the south side of Chicago and another 6 community areas on the west side of Chicago. And it occurred to me as this effort was funded through the Illinois Department of Human Services that it just didn't make sense to count people within these communities that were hard to count folk. It also made a difference for us to do social determinants of health screening. So there we were counting folks in these households, but also doing SDOH screening to make a determination as to what other needs were present within the household. And don't you know, it was a very interesting phenomena that we saw, Jackie, that the more we talked with folks about helping them, the more they were willing and ready to be counted. Because there was a fundamental message. Now, remember my background in social work. You all know I got to go there, right? So what was the fundamental message that folks were getting when you were asking them about the help that they need? You matter. You count. We value you. We value your existence. So yes, you must be counted. So the patients, 85% have at least one social determinant of health, at least one. Another 22% face unstable housing. An additional 7% are homeless. Another 37% struggle with food insecurity, and another 23% need transportation assistance. Now, another stat that's not reflected here is that we've got 60% of adults walking around, possibly in this room, who have experienced some type of adverse childhood experience, an ACE. 60%. Many of whom go through their adult lives with all types of unresolved conflicts from childhood. Think about the disproportionate representation of African American and Latino children in the child welfare system. Think about the disproportionate representation of these same children in the juvenile justice system. And think about the fact that many of these children grow up within these foster care and alternative systems of care that never have a home. And then they're going into adulthood. And then we think about what we see in terms of behavioral health conditions of folk. That's another whole lecture, ladies and gentlemen. So, progress to date. 199,000 potential attributed lives, and 44,000 of those are uninsured. 44,000, okay? Talk about health risk. Health risk, 21,000 health risk assessments completed, 107 total community workforce members, 107. We're talking about an army of folks now, okay? When I talked about a healthcare movement, 100 plus community health workforce members added to integrated care teams at local medical, social, behavioral health providers. 150 plus clinical leaders and community stakeholders recruited to provide governance and program oversight. Another $1.5 million in investment, 9,900 disease management participants, and 260 workforce members trained. That's an army. That's an army for healthcare. And it's like a snowball rolling down a hill. We're not done. There's more to come. All right, somebody said amen? All right, okay. So 19% reduction in social determinants at 6 months rescreen. 19% reduction. All right, what does that mean? Fewer people in the emergency room, fewer people being incarcerated or jailed, fewer people who are recidivists going back into state psychiatric facilities. You're having impact. Another 79% overall control rate for patients with hypertension after 6 months of engagement. Another 62% overall control rate for patients with diabetes after 6 months of engagement. Powerful outcomes. Nearly 600 will benefit from permanent supportive housing. We've got a relationship with the flexible housing pool. So we're housing people right now. Sheriff Dart said, you know, right over here at Cook County Jail, most of the folks that are detained in Cook County Jail, they don't need to be jailed, they need treatment. And even when they're released from prison, they don't have a place to live. So you know what they do? They go to CTA, that's their home. And what do you mean by CTA, Donald Do? They're riding L trains from stop to stop, from end to end. That's their home. And shelters. It's a desperate situation out here, folks. Almost 1,000 will benefit from food access partnership with Instacart and local grocery stores. You know, one of our mentors, Jackie Bishop, and I were mentored and a part of a program that Reginald Hatz Adams ran as the community relations director at Rush for over 45 years. And he created what they call the West Side Science and Math Excellence Network. But he was, was concerned that our children needed to be exposed to careers in science and math so that they could go on into healthcare careers. But then he backed up a little bit and said, wait a minute, folks on the West Side are still hungry. They don't have a chance to get nutritious meals. So he formed the West Side Coalition Against Hunger, just to deal with food insecurity. Organizations looking at medical homes and hospitals. Look at these numbers, ladies and gentlemen. We're talking about 2,358 folks with diabetes, another 3,500 HTN. We're talking about significant numbers here. I will go into patient stories, but I know we're crunched for times. I'm not going to go into all the case studies and samples of folk, but we've got folks, like this particular patient with, diabetes, no health care insurance. Bottom line, the woman now is eating better. She's taking daily walks, making new smoothie recipes. I need to be making a few new smoothie recipes myself, but the bottom line is that we have all kinds of stuff. Every time we meet as a board for Wellness West, we present one of these patient stories. It keeps us grounded in terms of the qualitative impact that we're having in each individual's life. It's so important to tell these stories, to keep people connected and making it real, okay? And we got, like I said, many, many examples of different patients that we've been able to have impact upon. So we talked about training and development earlier. We talked about coming up with a standardized curriculum. Wellness West New Hire Orientation. We've got that going on. We've got community health worker core skills certification training. We've got community-based organization CHW supervision going on. We've got disease management refresher training for hypertension, depression, diabetes, mental health first aid. By the way, over at Habilitative Systems, Inc., we've come up with something, you're going to love this one, called Gen Z Mental Health Ambassadors. Go figure, right? That we've got Gen Z folks interested in talking with their peers about what? What do you think? How about the increasing rate of suicide? How about cyberbullying and bullying within schools? How about the trauma that they're experiencing and the violence that they're experiencing every day as they try to navigate their communities? Well, I'm going to tell you, I remember what it's growing up on the West Side over here. And I am not kidding you when I say to you, from home to school. Now, I went to St. Malachi Catholic School on the west side of Chicago, and that was normally a 15-minute walk. We had to navigate about 3 different gang turfs just to get to school. I am not kidding you, okay? Talk about some trauma, talk about stress. Oh, that's another whole lecture. All right, so just giving you, again, some examples of professional development and training, patient consumer training, that's in there as well. There's all kinds of opportunities for us to train our patients and make sure that they understand their conditions and understand their role in healthcare. So we create all kinds of opportunities for this to occur as well. We identify potential candidates. There's application assistance. We do all of that on a regular, consistent basis. We also engage, of course, into, looking at stipend requirements. If we're going to help folk be a part of the educational process, well, yeah, let's give them some encouragement. So we, started doing the stipend piece as well. Patient consumer training program, here's just an example, the form that we use for that purpose. Again, I'm not going to take a whole lot of time on that. But I did want to quickly draw a connection because, when Jackie and I were talking about this presentation today and we were talking about hypertension and diabetes, and of course we want to also talk about the high correlation to chronic kidney disease. So we're looking at over 1,400,000 folk with estimated adults living with chronic kidney disease in Illinois. 9 to 10 adults do not know they have kidney disease. Again, for many of y'all, these statistics are not new. Another 34,000 plus Illinois residents are living with some type of kidney failure. And then, of course, we realize that diabetes and hypertension are common risk factors for kidney disease. So naturally, Jackie and I are thinking that there's an opportunity for collaboration between NKF and Wellness West, because with all the screenings and trainings that you all are doing and all of what we're doing, there's a lot of potential cross-fertilization, if you will, for us to be able to refer members and patients to each other for total health care. So when we look at, of course, chronic kidney disease correlation statistics, diabetes and hypertension can increase chances of kidney disease. So 1 in 3 people with diabetes have kidney disease. 1 in 5 people with hypertension have kidney disease. Diabetes, hypertension make up 2/3 of chronic kidney disease cases. Diabetes and hypertension can damage blood vessels and lower kidney function, leading in kidney disease. Compared with white folks, black people are nearly 4 times more likely to develop end-stage kidney disease. Hispanic people and Native American people are more than twice as likely to develop end-stage kidney disease. So we know that there's a natural connection here. You know, this conference today, this session today is an opportunity for us to elevate what we understand about what we're trying to do here in terms of having impact in these communities and make sure that people live better, in fact, feeling much, much better. This is our board of directors. Ms. Sanchez is our board chair from Humboldt Park Health. I'm the vice chair. You see Dr. Ansel from Rush, Tessana Whiskey from Loretto, Mohamed Quadrago, the new CEO of at Access, Bessie at Alternatives, Esther over at Alvivo, Andrea at Cook County, Karen at Sinai, Brenda at North Lawndale Employment Network, and Karen over at Lurie Children's Hospital. Quite a great group of folks, would you agree? And listen, you know, we're talking inclusion here. We're not trying to exclude anybody. We're trying to find a way to bring everybody to the table. Now, last thing I want to say as a mental health practitioner from way back in the day, when I would do a workshop or a seminar, you know, I would say, well, folks are always talking about how do you deal with your anger and how do you deal with the issues of the day. And we have often heard in our lifetimes folks saying something as simple as, so-and-so has just made me mad. I would step back and say, well, why would you give someone that power to make you mad? The other part of the situation is real simple. When we think about tea, we normally think about drinking tea. As a psychotherapist, I said, let's look at that a little bit differently. Let's think about our thoughts, expressions, and actions and drink our tea daily. When we talk about luck, what is luck really? But living under conscious knowledge. This is about knowledge, this is about awareness, this is about education, this is about making sure that folks are more conscious of their choices. And the more conscious we can become of our choices, healthcare choices, social choices, just think about it. Half the battle in life is controlling what comes out of the mouth and what goes in. I think I better stop there. Thank you all so much for this opportunity.
Thank you.
Okay, good morning. Good afternoon. What time is this morning? All right. All right, can you feel it? Can you feel it? Can you feel the synergy in this room? There is definite synergy in this room. The fact that there's work to be done, we're working, and there are people in this room who are interested in doing this work together. We also have heard there are a lot of people working together to get it done. So I feel it. I feel the synergy, and I appreciate you all for being here and those who've come before me and given this important information that we need to know to continue it. So I'm Monica Fox. I'm the Senior Director of Outreach and Government Relations for the National Kidney Foundation of Illinois, and I am delighted to be here before you today. I am also a very grateful kidney transplant recipient who celebrated 7 years in November. Thank you. So today we're here to navigate the roadmap to CKDintercept and health disparities, and that's very appropriate because having kidney disease is definitely a journey, and it's a journey that I share with 37 million others. You've heard the statistics, and like me, 90% don't know it. Therefore, we know there's many disparities. In November of 2013, I went to the ER. Elizabeth mentioned this. She told my story already. I went to the ER, and I was suddenly diagnosed with kidney failure. I'll never forget my sister saying these words. I was in a total daze, but the words still echo in my head. They say your kidneys have failed. You have a fight ahead of you. What do you want to do? I said, I have to fight. Olivia needs me. Olivia's back there in the room. She still got me, thank God. So after putting me into an induced coma and stabilizing my heart function, I woke up 4 days and had had the first of what turned into 3 years worth of dialysis treatments. However, my journey took a turn for the better in November of 2016 when I got my kidney transplant. So working with the CKDintercept project gives me hope. Hope for those that are coming behind me on this same journey. They're beginning this journey, and especially for those that don't know it. As I work with the Illinois Kidney Disease Education and Prevention Task Force, which Jackie mentioned already, and so did Elizabeth, I'm encouraged for Illinois in particular. It's an honor to work with our co-chairs, Senator Maddie Hunter and Representative Maurice West, to strategize ways that Illinois can help move kidney care up the continuum. Members of both these groups believe that education and awareness are extremely important. And personally, if I had known that protein spilling in my urine was a sign of kidney disease, I would have asked for more testing. However, if everyone gets tested earlier for kidney disease, by a certain age, that probably would have helped me too. And it definitely will help others along this journey. I also happen to have the privilege to be a member of the Links Incorporated, where we're working together with the Black Care Project, which is sponsored by Baxter. And we've educated over 60,000 people in our service areas in less than 2 years. And Donald talked about, investing, that ideas, come, but you have to, they need to be sustained, and Baxter has already committed over $1 million to that project. So as I close, I just want to thank all of you for your interest, your efforts, and involvement in creating a roadmap to earlier diagnosis and care for kidney patients. We are hopeful, we are grateful, and the journey continues. Thank you.
I don't think the mic's on. It is, okay. So we've been speaking of different initiatives. We've been speaking of different social aspects and financial aspects. My job today is going to be to tie all of this together. Ms. Fox and Mr. Dew have spoken about a synergy in the room. I'm going to lead by saying I did not speak with anyone prior to this. Every topic that was spoken about today, I have 1 or 2 slides on. The unfortunate thing about saying 1 or 2 slides means it's going to be a little bit long, so I ask your patience. And I thank you for inviting me to this, and I thank you for your patience and your attendance. And I'll get into a personal introduction in 1 second, but this is what we're here for. Our under-resourced populations on the west side of Chicago, in Chicago in general, in Illinois, have been suffering with kidney and health disparities since the 60s. I had heard this quote by Martin Luther King Jr. Before, but I didn't know that he gave this quote in Chicago. So health disparities and the benefits that can be obtained through investment have been known since the 60s. But what have we done so far, and what are we going to do next? So this is who I am. Keith Hopkins, a University of Illinois product. Thank you. I did nephrology at University of Wisconsin-Madison, and I did hypertension at University of Chicago. And again, we're here to talk about health disparities, specifically kidney health disparities. Do we know what to do and how we're going to do it? And most important is why. Is the effort sustainable? So as we've heard today about value-based care and social determinants of health, and this is the definition of value-based care. It's not so much a cost issue, but it's the intersection between cost and results and quality. So the talk today has kind of peripherally defined value-based care. My job is going to be to link value-based care with kidney health and health disparities, and I'm going to leave you with next steps, what we can do next. Because as Mr. Du defined or stated, we can't just state the problem. We have to say, what are we going to do next, and how are we going to do it? Value-based care is not all data, even though data is very important. The patient is at the center of it. It's not just punching numbers into a system. And the NKF and other of our stakeholders are invested in keeping the patient at the center of care. So the first part of the roadmap that the NKFI has is increasing the educational opportunities for providers. And why? Well, when you know better, you'll do better. Next, increasing the public awareness of CKD. Ms. Fox just mentioned how the way she found out she had CKD. When I was before college and in medical school and in residency and in fellowship, I heard regularly, your kidneys are sick, but once you get on dialysis, we'll take care of you. That's not the way to do things. But that's the way it was, and believe it or not, that's the way it still is in a number of different institutions. The NKF is impacting that and making it more of a preventative care. A stitch in time saves 9. That's the way NKF is applying it to medicine. And the social and racial and financial disparities are known and have been spoken about. Once these are addressed, and through prevention, we can make a difference. And then we have to shift the reimbursement towards quality, away from a life-sustaining to a life-saving model. And I'm not speaking against hemodialysis. Hemodialysis is necessary, but at best, it's a life-sustaining. No one really gets better on dialysis. They stay where they are. But if we can get people's blood pressure under control, get people's weight under control, dietary options under control, we can prevent them from getting into that downward spiral. The key point of what the NKF is interested in doing is in 3 to 4 stages. One is prevention. Prevention is the best form of care. And as I mentioned, better diet, weight control, diabetes control, and blood pressure control. Next is to get clinics and neighborhood groups to do the needed screening. Blood pressure screening used to be not done very often. But now when you go to any clinical event, any church event, you're going to have a table where there's doing blood pressure screening. As Ms. Fox mentioned, what if we did the same thing for kidneys? What if we did a blood pressure, weight, and could somehow do urine proteinuria screening? What difference would it make? And the answer is huge. But once someone is on and needs renal replacement therapy, let's get them into the best therapy: peritoneal dialysis, home hemodialysis, transplant. When I was at University of Wisconsin, the 2 years I was there, I will be generous and say I had one patient of color, one black patient interested in transplant. Mr. Du mentioned he's not going to preach. I'm going to preach. Black people don't like transplants. They don't. But the best form of renal replacement therapy is what? Replace the renal. Transplant can make a difference. It can extend life. It's a difference maker. But we've got to, as providers and as community health workers, as people who are informed and reaching out, we've got to have this information. We've got to be able to convince people that what we're doing is going to make a difference in their lives. And lastly, when people reach the end of the line, It should be a patient-informed decision. I have a problem with someone on dialysis at 98 and has heart conditions. I'm not sure that's what they would want. I don't know how many providers ask, here are our options, what's best for you? What's best for your family? It's got to be a patient-informed decision, because we are going to keep doing what we're doing, but that patient's decisions, hopefully it won't be in an emergency department, but when they're in your office, that patient's decision is going to impact them, their family, their lifestyle, their life. We've got to make it an informed decision. So, about 17 years ago, and the reason I put this slide up is because just the confluence of numbers. About 17 years ago, I began my journey as a nephrologist. About 17 years ago, social determinants of health really reached our language. An article in Journal of American Medical Association in April of last year says it takes 17 years for practice guidelines to reach the forefront. And even then, only 1 out of 5 evidence-based measures make it to the clinic. What are we doing? What are we waiting on? We've got the data. Let's not wait any longer to understand, communicate, and remedy these issues, because it goes beyond health issues. It goes beyond the textbook. These are social issues. These are life issues. Sooner or later, 5 years or so, and this is my prediction, health is going to become a national issue in terms of safety. An unhealthy nation cannot defend itself. So social determinants of health has been brought up. It includes economic status, education, neighborhood and housing environment, employment, and access to health care. When I first heard about this when I was at Yale, I said, well, why don't we talk about the social drivers of health? Because social determinants of health are external interventions, external limits, if you will. What can we do personally? What can we do on the ground level as providers and as patients? And now social drivers are becoming a more commonly used term, but I don't think it's used in this way. And that is to individually impact health and healthcare inequities. And I don't see the pointer, but the exercising figure is for exercise. How much better would our lives be if we simply took 15 minutes a day to exercise? In Chicago, you hear a lot about food deserts. That is why access to quality foods is so important in terms of our overall health. Family health history and health literacy are vital. And lastly, just the time to relax, to sit and take 10 minutes where you don't hear sirens, where your child is not hungry, where you're not worried about bills. All of these things impact our health on an individual basis. And the NKF and the people in this room have the ability to work on the external determinants and the internal, if you will, the local drivers. And that's what we're here for, to learn how to best do that. So when we fail in doing that, we run into these barriers. Poor CKD knowledge. And what do I mean by that? Screening frequency. The urine albumin creatinine ratio, looking for protein in your urine, looking for serum creatinine. All these things have to be done regularly. I'm not going to be saying should, because we all know the should. They have to be done regularly. We have to be more direct with our providers and with what the needs are. The cultural disconnect between providers and patients is known, but we don't speak about it. If I cannot trust my physician, why would I listen? Why would I do what they say? There's data out there that says that there's a much greater adherence when you trust your patients. In my practice, I've been give people homework assignments because they can put it on their refrigerator. So when they go to get that extra icy or extra can of soda, they can go, wait a minute. Oh, God, Dr. Hopkins put that on my homework. And I asked them to put it on their refrigerator to refrain. And then when they come back, I asked them about it. It's not just giving them stuff. It's, hey, how is this going? How are you doing on stopping smoking? How are you doing on getting your blood pressure under control? Are you having any side effects from your blood pressure medicines? And then lack of known resources for CKD patients. This is where community health workers come in. Clinicians have a bandwidth. And as much as we're asking, as much as we need to do in order to get better care, clinicians don't have the bandwidth. So that's why we have to expand the interventions and who are doing these interventions, community health workers. And when we do these things, we will overcome these barriers. These barriers are not, they're inherent to the system, but they're not permanent. Poor CKD management. Prevention is always key, but it's not applied equally. Mr. Du mentioned the lifespan from just a simple couple of blocks. Well, that's by preventative care. It's by taking time to sit down and talk with your provider, not while they're typing, not while they're waiting for 3 hours for you to get in. Time, we're not gonna be able to fix time. But when we're on time to see our patients, when providers are vested in patient care, prevention becomes real. And Mr. Du also mentioned the risk, CKD 3A, the very basics of CKD, doubles the risk of hospitalization, and there's increased risk for stroke, cardiovascular disease, and it reduces the quality of life that we have. The data was also mentioned that the number of people in the United States, 37 million in the United States have CKD. Locally, that's 1 million. That's 1 out of 7 people. And 90% don't even know that they have CKD or what defines it. Most providers think CKD is a GFR number, and it is, that's important. But when you look for proteinuria, you can make a difference. 30% of those with diabetes also have kidney disease, but fewer than half of these people get both of the above tests. They're looking for the creatinine, looking for the GFR, and looking for proteinuria. The NKF has developed a kidney profile panel which groups all these tests, so when you order one, you can order all of them. And it's a screening test. It's an intervention that makes a difference. And we need to do annual monitoring of kidney function and health. And when we do these things, we'll increase the primary care experience and information and knowledge. Again, I mentioned bandwidth, but this information needs to get out there. We can't wait 17 years for our frontline physicians to make a difference. But also the last paragraph is important, and that's engaging the non-traditional healthcare providers, our faith-based organizations, our pharmacies, our community centers, food banks. If we get all of these people involved in the screening, in the conversation, even if it's an NKF handout that says, hey, have you had a GFR done lately? Have you been screened for proteinuria? Just a reminder, it's a piece of paper. But when we advance the community awareness of renal disease, we can make a difference. And again, I've come up with the 3 Fs in terms of what the community can do, what we can do to affect the community. Get a good family history. One of the risk factors for CKD is simply a family history. Second, healthy food choices. We're working on food deserts, but even we have to have people make wise food choices. What you put into your mouth makes a difference on what comes out. And lastly, physical activity. It had to match the 3 Fs. But that means getting enough sleep, stopping smoking, and finding healthy ways to cope with stress and depression. All of these things are covered under these 3 Fs. And if we take time, a minute, to have a conversation with people, it can make a difference. So why is it important? Richard Allen Williams, a colleague of mine from the West Coast, says that as we consider opportunities to advance programs that address disparities, Medicare Advantage, a value-based care method, provides a roadmap for interventions and programs that work for seniors. We need to keep that in mind. States have innovation models where they get funding for what can you do to affect social determinants of health? What can you do to make a difference? Illinois has a SIM. A lot of other states have SIM. We've got to start using these for our patients' sake. And like Mr. Du said, I will also slow down a wee bit. Why is it relevant? Why is it good for us from a stakeholder perspective? It's a stronger control of healthcare costs, fewer patient interventions. And what I mean by that is costly interventions. What I mean by that is emergency department. Less provider burnout. You don't have to see patients. One of the problems with internal medicine when you're in medical school is you never see people get better. Surgery, you come in, they get better, or they get worse. But internal medicine, it takes 10 years to make that difference. But when you make a difference, when you do inch steps, Mr. Du introduced data where in 6 months you can see a difference in terms of blood pressure and hypertension and diabetes control. If we start doing that on a global perspective, there'll be less provider burnout. There'll be less depression from a provider perspective. And I have a quote from Humana that mentions preventative screening works and is done more when there's a value-based care model. And it's the right care at the right time. Mr. Du mentioned, is this sustainable? Value-based care and these forms of methods, these methods show a 35% savings over a typical fee-for-service Medicare. There is a significantly lower rate of avoidable hospitalizations, specifically in the complex chronic condition patient. And lastly, providers earn 3 times the Medicare physician fee schedule payments. So I've given you the reasons why caretakers, providers, and patient stakeholders are coming aboard. What we need to discuss is each person in this room willing and ready to do so? The 3 tools that address data in value-based care, that address value-based care, number 1 is data, because it drives reimbursement, and it helps with the decision-making. Communication and respect, making that connection with the patients. Us being vested in them feeling that we care. And last, private sector partnerships. Every company is a healthcare company. And what do I mean by that? Healthcare impacts workforce. We saw this during COVID. If our patients are not well, they will not stay on the job. So ending health disparities. One of the cartoons on here says, end physician and community inertia. So important. But also in the bottom right, it says, taking data from the lab to life. And my last slide is just patient steps, what we can do and as providers and what we can do as patients. So I thank you for your patience and me flying through this as fast as I can, but I wanted to touch on everything that was already talked about. And I'm so glad I was last and not first, because I would have spoiled other people's data. Thank you.
I want to thank Monica and Dr. Hopkins for their presentations. And at this point, I'd like to also, so Akila, why don't you stand up? I'm getting the slide. But, so while she's doing that, I'd like to thank the National Kidney Foundation so NKF of Illinois, we are an affiliate of the National Kidney Foundation. And what I'd like to do is thank the National Kidney Foundation for their support of the CKDintercept initiative. And I also, is this the How Will You Help? Did I miss that? How Will You Help?
Oh, this is it.
Okay, how will you help? All right, in terms of you can engage the presentations, the critical conversations, those of you that can do the scan. And so given that we're a little over time, we want to invite you, those that have placed questions in the chat, we will get back with you. We will confer with our speakers to get back with you to address those questions. We're very excited. We hope that the program today really provided thought, provided a 360 view of where we are, not just with kidney disease, with chronic disease, with health equity, and with changing the trajectory and impacting populations. So what I want to do now is introduce our population health manager, Akila King. So Akila, she's like, okay. And so Akila is the point person that is going to continue to help drive this forward as we reconvene with our work groups. And remember that intersectionality component where a number of us are involved in different initiatives and consortiums. So what we're doing is being respectful of time and looking at where the work groups intersect with work that is being done. So we're very, very excited. We understand the data opportunity and the documentation, and of course, as Donald and others have mentioned, and the investment in funding. So with that, I'd like to, to advance to thank what we did today. We did a combination, talking about leveraging, we did a combination of utilizing this opportunity in Kidney Month to update, provide our CKD Summit update, and our World Kidney Day, which really for us is week, which kind of is a month, but you know, our World Kidney Day experience. And so for the sponsors for our World Kidney Day, we want to thank Associates in Nephrology, NANI, which is Nephrology Associates of Northern Illinois and Indiana, and of course, UI Health. So we really appreciate the support as we continue to move forward. And we are reconvening our 4 work groups: clinical considerations, policy payment, and quality measures, wellness and prevention, and engaging community and community-based solutions to help advance our roadmap. So let me see, I think I see some of our work group facilitators here. If you could stand. Some were here before. I see Laura. And so, well, Dr. Hopkins, you don't have to stand. You don't have to stand. All right. Okay. And I know that there were others that were here before, so we're getting the band back together, as I like to say. The band really never ended. We just morphed into expanded directions, and Akila will be contacting you. Thank you to everyone participating today, and of course, I really, really want to thank the dynamic team of the National Kidney Foundation of Illinois. I want to please, for those in the room, please stand. Want to thank, already talked about with Akila, want to thank Rachel for your leadership, everyone involved, Sarah J. I'm looking at don't want to leave, those that are, I would say, in the back, a dynamic team and a committed team to change this trajectory of kidney disease. And thank you for your time. I think we still have food outside. Okay, what is outside? Lunch, all right, boxed lunch. You're welcome to bring it back in here if you want to have a conversation or take it with you. So wishing everyone a wonderful day.